and sparing everybody the interesting case of a port. I have no disclosures. That's what we'll be talking about today. We'll start with a case presentation, a little bit of basic science and content review, give some historical context, take a look at the literature, describe open cholecystectomy, and then finish with the cost of medicine. So our case starts with an 81-year-old male. He had a history of grade 4 liver laceration that was managed non-operatively after an MVC 2 years prior. He was transferred to our facility from Murphy Medical Center after a week of abdominal discomfort, which became acutely worse over the course of the past day. He had fevers up to 104 degrees Fahrenheit, associated chills, nausea, and vomiting. He had a past medical history of BPH, taking Flomax and finasteride, but was otherwise healthy. Surgical history included a Roux-en-Y gastric bypass. He had no known drug allergies and had no otherwise contributory family history. On physical exam, he was alert and oriented ×3. He was on 2 liters nasal cannula without much respiratory distress. His abdomen was soft, but he was distended and tender to palpation in the right upper quadrant with evidence of localized rebound. Prior to transfer, he had received 4 liters of lactated ringers and had been maintained on just a little bit of Levophed there, and then his arrival blood pressure was 111/65 with a heart rate ranging in the 80 to 95 range. Lab values when he got to our facility compared to the ones from Murphy. He started to mount a white count up to 13 from 5. His crit had dropped pretty good there to 28 from 40, and he was manifesting lactic acidosis with a pH of 7.17 and a lactate of 3.8. Note his T-billy was only 0.8, and his had a little bit of a transaminitis. He had a CT scan done at the outside facility, which we'll take a look at. Immediately see some fluid around the liver there, the spleen. And then as we get to where the gallbladder is, he's got evidence of a thickened wall there with fluid in the gallbladder fossa and evidence of a ruptured gallbladder with fluid down the paracolic gutter and then moderate amount of free fluid in the pelvis. Based on his symptoms in his CT scan here, he had presented with abdominal pain, high fevers, and in shock at this point. But admittedly, the bilirubin was only 0.8. This is also seen on the coronal imaging. Again, all the fluid under the liver and in the pelvis. Some renal cysts. Sagittal imaging. Which demonstrates the same. So, kind of like we alluded to just then, given the patient's clinical history, week of abdominal discomfort, recent fevers, physical exam findings of localized rebound, degree of free fluid present in the peritoneal cavity and under the liver, diagnosis of septic shock, secondary gangrenous cholecystitis with gallbladder perforation was presumed, and the patient was taken to the OR for exploratory laparotomy. Intraoperatively, the abdomen was entered with a subcostal incision, and a large amount of blood and clots were encountered. The gallbladder appeared to have ruptured and had associated black pigmented stones scattered throughout the abdomen. There was gross bleeding noted to be oozing from the perforation. So on the intraoperative picture here, which you can see the gallbladder labeled. Subcostal incision with evidence of perforated gallbladder and then associated, I don't know if you guys can appreciate it here, but these sort of black pigmented stones, the resolution is not as good on your screen, but open cholecystectomy was performed. The liver also appeared nodular, and a liver biopsy was done, and hemostasis of that biopsy site was achieved with Everest. A site of active liver bleeding was also noted after the gallbladder was removed, which was initially temporized with the argon beam, but required hepatography with the mobilization of an omental pedicle flap. This is an additional photo here. You can sort of see a pigmented gallstone down here by the suction in contrast with the patient's skin. So that's like blood, frank blood clot and oozing. Yes, sir. Yeah, that's the perforation. An intra-abdominal drain was left, and the patient was closed. He received 1 unit of packed red cells in the OR. Postoperatively, he remained intubated, went to the ICU with pressure support, but by postoperative day 1, he had been extubated and weaned off pressors. He was transferred to the floor the next day, and by post-op day 4, was tolerating a regular diet, ambulating, having bowel function, and deemed stable for discharge. His pathology specimen revealed acute cholecystitis with evidence of mucosal ulceration and hemorrhage, and his liver biopsy revealed just a bile duct adenoma. So, although the patient's initial presentation suggested gallbladder perforation secondary to septic shock and gangrenous cholecystitis, his intraoperative findings, which we saw on the picture, were actually more consistent with hemorrhagic shock secondary to the formation of likely what was either an arterio or venobiliary fistula that had formed after his trauma and then led to the formation of pigmented stones in the gallbladder, which obstructed the cystic duct, leading to distension and perforation. And so I thought this case presented sort of a unique opportunity to discuss a very, very common general surgical topic that we are all intimately familiar with, but sort of a unique presentation of it with a little bit of trauma overlap. His shock states, thought we could talk about. This is sort of the kind of diagram we think about when we talk about the folks' presentation in shock. Ones we're familiar with, thinking about our patient in septic shock, effectively manifests as vasodilation secondary to circulating inflammatory mediators, and then the body has the compensatory increase in the cardiac output and to attempt to increase your perfusion. For the hypovolemic shock or hemorrhagic shock, for which this patient later became clear that was what was going on, the blood loss is what leads to a decrease in your cardiac index, and your compensatory response is the increase in your systemic vascular resistance and decreased venous capacitance to shunt your blood to the arterial system. Additionally, we've had the classes of hemorrhage below, evidence of class 2 or so shock is probably what we were dealing with in our patient, given the fact that his heart rate had remained a little bit elevated actually at the outside facility, up in sort of the 110s or so, and then blood pressure had to be controlled with Levophed. And again, this was from cholecystitis, which we see as secondary to formation of gallstones. And so I thought we could take a look at some of the pictures here just to differentiate between cholesterol gallstones, which we, again, see very frequently form the majority of the time in our patient population with cholesterol supersaturation. That's our obese population that have oversynthesis of the cholesterol, which is normally solubilized in the bile with the bile salts and the lipids, but the level of cholesterol becomes too great and oversaturates. And then our patient, this is just a picture of pigmented gallstones here that you can see in cirrhotic patients or anybody who is having increased hemoglobin processing and elevated bilirubins, such as a patient who may have had hemobilia. So hemobilia and hepatic trauma, first described in 1647 by this man, Francis Glisson, during the autopsy of a guy who initially had a stab wound to the right upper quadrant, and when they evaluated him, noted that his blood was actually coming from the biliary tract and that he had a GI bleed. It was later identified by Quincke's triad of hemorrhage, right upper quadrant pain, and jaundice in the 1870s. There were some scattered case reports by the 1900s, and then it wasn't until the 70s or so when Sandblom published a large case series describing it, and then further case series by Yoshida and Green in 87 and 2001 respectively. And this pie chart progression kind of details why we see hemobilia. Used to be, certainly if you look in the 72 case series, only 17% was iatrogenic, with the majority being due to trauma. That's that 38%. And then as you move through and look at Green's case report from just under 20 years ago, the overwhelming majority of this hemobilia is caused by iatrogenic causes as we start to do more and more procedures and things on the biliary tract and liver and get better technology with that. Like I said, trauma is certainly a cause, and as seen in our patient, but we see it with our percutaneous approaches. So the liver biopsies we do, the percutaneous transhepatic cholangiographies that we do, or leaving the biliary drains, TIPS procedures, and radiofrequency ablations of the liver. Endoscopic procedures can lead to these things. So ERCP, especially if they do sphincterotomy or any further manipulation with stenting and things of that nature, puts the patient at risk for developing hemobilia, as well as endoscopic ultrasound of pancreatic biliary lesions, if those are being biopsied at that time either. Surgical complications, we do a lot of laparoscopic surgery up there, and cholecystectomy and liver transplant and Whipple procedures are certainly not absolved of that risk. You also see hemobilia associated with malignancy, like cholangiocarcinoma or pancreatic cancers, hepatocellular carcinoma, or metastatic disease. If you have a chronic obstruction leading to inflammation and erosion of the ducts, you can see fistulization there. And then in places around the globe, and certainly in China, Korea, and Vietnam, the liver flukes, roundworms, and echinococcus are responsible for their formation there. So when it's encountered, it's frequently seen in the form of a GI bleed or biliary obstruction, as the blood in the biliary ducts clots and then masquerades as a stone or obstruction. We sort of discussed Quincke's triad earlier of the hemorrhage, right upper quadrant pain, and jaundice, which is frequently, or should I say infrequently present, and in one study was as low as 22% of their cases presented with that. Nowadays we can get a CTA on these folks to make the diagnosis. It's the first choice when you're suspecting hemobilia and has a high sensitivity. only up to 60% of cases of hemophilia can be diagnosed via the EGD, like this picture shows, where you see the blood clot at the ampulla. And so as the etiology of the hemophilia has changed, so has our sort of treatment strategies. Most of the time, if it was secondary to an iatrogenic trauma of some sort, be it a percutaneous or IR-based procedure, a lot of the times that was amendable to an IR-based treatment strategy. And so angioembolization is frequently employed. But for minor hemophilia, you can use supportive care and just watch it with IV fluid management and then correction of any of the coagulopathies that the patient may have. And then occasionally, based on the location of your fistula, endoscopy or ERCP with stenting can be not only diagnostic but therapeutic with control of the obstruction as well as the bleeding. Again, the angioembolization that we discussed, you can those are used more frequently in the more proximal lesions, and they have a host of agents to get to more tortuous portions of the arteries, and in terms of liquid agents even, not just the coils that we're familiar with. And then last resort, as in our patient and folks who are unstable, have evidence of cholecystitis as well, those patients need surgery. And so open cholecystectomy is something that we do occasionally, and early conversion should be considered in the setting of patient's distorted anatomy. But because our patient presented in such a delayed fashion with evidence of shock, the open approach was chosen from the outset. It starts with the subcostal incision, 2 finger breadths below the costal margin, and then the anterior and posterior fascia are incised and the peritoneum is entered. Bookwalter retractor can be used to expose the gallbladder, and then the visceral peritoneum is dissected from both sides of the gallbladder in this top-down approach that you see shown here. And then once the gallbladder is taken off of the gallbladder fossa and liver bed, the skeletonization of the cystic artery and duct can be done, and as you see, the right angle clamp there under the cystic artery before clipping or suture ligating it and dividing it. And in our patient, as well as in many patients, drains can be left to control a bile leak should one develop. And so the case of gallbladder perforation with active hemorrhage secondary to the formation of an arterio or venobiliary fistula, managed with blood product resuscitation, open cholecystectomy, and hepatography. In this patient, I thought kind of tied in a few components of different surgical management, and was a good talk about something we commonly see. And then we finish with the cost of medicine there. Take any questions.
What is Surgiflow?
Surgiflow is sort of a liquid hemostatic agent to gain.
Is that the picture of it at the bottom there?
That's Arista at the bottom there. That's your kind of the spray, snowy stuff. It's hard to.
And what's Everest?
Everest is what you see at the top there.
Why would it be so beneficial?
It's I believe it's
I'm not familiar with it. I'm asking a question. I guess the rest of it. Bob,
that stuff's amazing. Everest, if you have trouble, mobilizing the splenic flexure, diverticulitis, or something like that, and get a capsular tear on the spleen, you cut a little piece of that and put it on there, and works great. Used it last week. Somebody's septic shock, coagulopathic, got the spleen irritated, put some of that on it. It's expensive. Similarly for liver trauma, I've stuck it on bad liver coagulopathy, bleeding, and it just sticks and adheres and stops a lot of oozing. That was an interesting case. I agree. Do you have a CAT scan from when he had his liver trauma?
I don't. That was
I
unattainable.
think that your theory is interesting, but I'm not sure that I'm completely sold on it, because if he has a biliary vascular anomaly that caused the pigmented stones, I think there's a good chance it would still be there. And I didn't see anything that looked like a pseudoaneurysm or a blush on the CAT scan that you showed. I'm just trying to think about that. I don't know. I think an alternative theory is he had pigmented gallstones and he had bad cholecystitis and presented with a ruptured gallbladder. But
yeah, I think the way that I rationalize it, I know that the venobiliary fistula can form and maybe be in more of a low pressure system and sort of present as more of an indolent sort of case. And if the patient had maybe, I mean, I know we're sort of grasping strings, but if the patient had evidence of maybe adductive Luschka or some sort of component that led to direct biliary drainage.
Actually, this patient had a bile duct right there that we had some difficulty ligating, and that's one of the reasons why we left the drain right at the side of the rupture where the laceration was bleeding, and there was a big bile duct right there that we finally were able to control and ligate. And they were adjacent to each other and draining into the gallbladder side in segment 5, right there where that laceration was. So there was a big bile duct.
I don't understand that now. Was this a right hepatic duct, a duct of Luschka, what?
Looked like a enlarged duct of Luschka that was.
It wasn't the right or left hepatic.
No, it wasn't
Okay,
the main. It was on segment 5, more like towards the lateral aspect, in segment 4 or the middle, but it was right there on that side where the laceration was, and it was deep in the fossa, in the gallbladder fossa, and we had some difficulty, but we were able finally to ligate this duct of Luschka and also control the bleeding, because there was significant bleeding at that side also from the liver parenchyma. So kind of weird, because
what was our estimated blood loss in this case? I mean, it would have.
It was reported as 100 mLs in, I imagine, in addition to what the.
You already had like
that wouldn't explain that much shock, I wouldn't think.
Yeah, he had like a liter of hemoperitoneum.
A liter. Yeah, that's what I thought. He had pretty significant. Level of blood loss. It's been my experience, it's pretty uncommon for gallbladders to perforate completely, and certainly to bleed like that. Have y'all had much? And the other thing is, assuming that these pigment, I don't think that you can necessarily assume that the pigmented stones arose as a result of trauma, because that's more of a metabolic consideration. I mean, it's not something, I don't think.
Yeah,
what do y'all think? I mean, you two trauma guys.
This is weird, because when I opened this patient, I thought when I did the exploration, I thought it was going to be a necrotic gallbladder, and but you can see in the picture the gallbladder is pink, and it's not like the typical inflamed.
Right. Yeah.
And we took those biopsies from the adenoma. I actually presented this patient in tumor board to see if this adenoma and the liver had any significance for neoplasm, and they didn't think much of it. They said it needs to be followed up, and it's going to be followed up in 6 months. Because we were thinking, does he have a neoplastic process that is causing all this? Okay. And those, because you have multiple lesions in the liver, and we biopsy those, and there were biliary adenomas, which is supposed to be indolent, and they don't usually become malignant. But that's going to be followed up as well. But
so you're going to get a follow-up CT on him?
Mm-hmm.
Yeah. Okay.
Yes.
Yeah. Bob, you want to comment on that?
I'm not trying to beat your case up. I'm just trying to understand this. The gallbladder was viable. It wasn't gangrenous when you just said it was pink.
Yeah,
so it's hard to tell from the picture. Yeah. So the gallbladder is viable. So in your research, did you find some data about biliary venous fistulas? Because I've always assumed that they were all arterial, because the venous system is a low system,
right, it's
low pressure system. And did you see that?
Yeah, it's mentioned. It's rarely, if ever, a complication or consequence. It never presents, but it's mentioned as sort of, I think, in theory.
Well, undoubtedly this was somehow related to his liver trauma, just a delayed complication of it. Another thing I was going to ask you, because I didn't hear you say it, I just may have missed it. Who's the guy in the picture, the big hair that first described?
Oh,
Yeah, I didn't
Francis
hear you
Glisson?
say his name.
Glisten?
Glisten.
Okay, Glisson, all right. As of Glisson's capsule?
Yes, of
Okay.
Glissen's capsule.
Yeah. Well, I have.
Man, sister.
Couple of points you can add to one, and we should have reported it now that I see your list, because the cause for hemobilia, as a resident, I had a patient with a ruptured hepatic artery aneurysm into the common bile duct as a cause of hemobilia, which ended up being a very challenging case as it turned out to be. And again, when you talk about treating hemobilia, I think you said we ultimately end up with surgery as a last resort. It's really the first resort, and it's picking the point, except that you start out with what can we do to treat this without having to do an operation like you did in this case, because it is interesting that the embolization and those techniques really have worked very well, in my experience, at least when we develop hemobilia after trauma. In particular, those AV fistulas inside the liver really do respond well to that. Bob, you going to comment?
The only other comment I'll make about angioembolization for hemobilia after trauma is get them to put the metal coils. We've had them use the gel foam, and they've rebled to disastrous consequences.
Okay.
So, and I think our IR people are aware of that. Happened
Okay, no, that's one
several
I
years
didn't-
ago,
I
and
yeah.
metal coils are the way to go. You don't want
Right.
to reperfuse that if it happens.
Yeah. Okay. Because I mean, it's a really frightening experience when you have somebody in shock from hemobilia. I will have to say, yeah, there's a lot of things going on. And the drain in the gallbladder, just be aware that that was something that was routinely done in elective cholecystectomy when Dr. Fisher was a resident and I was. Now, that was proven later on to not be a good thing to do in a routine cholecystectomy. Case like this, and the cases that if you're in this day and age, if you're having to operate on somebody and do an open cholecystectomy, it's likely you're going to need to consider that. Although most everybody proved a long time ago, it really doesn't do anything other than treat you as the doctor. It doesn't really help the patient a whole lot. But anyway, we got a lot of noise here, John. John, we got, okay. All right, let's have the next case.
Okay.
So I'm going to be presenting an interesting case of colonic stenting. This case was done 2 years ago, and I don't have any disclosures, and I'd like to thank Dr. Moore for helping me with this case and allowing me to present it. So initially, this is a 67-year-old male. He had multiple medical comorbidities. He initially presented with a metastatic obstructing left-sided colon cancer, and he underwent placement of a self-expandable metal stent that was uncovered for palliation of his obstructing left-sided colon cancer that was noted to be about 50 to 60 centimeters from the anal verge. After the procedure on the 13th, he began to have increasing abdominal pain. He received a gastrograph and enema that revealed contrast extravasation from the proximal end of the stent. He was unable to give a history because he was restless and drowsy, and at that time, surgery was then consulted. He had a past medical history that included morbid obesity. He was on HOMO2 for COPD. He had hypertension, diabetes, Parkinson's, neuropathy, peripheral vascular disease, so he obviously had plenty of comorbidities. He had had previous vascular stenting of his left and right common iliac arteries. He had also had an amputation of his fifth toe. He was on the medications listed, and he was noted to be a 150 pack year smoker. So these are the vital signs that were initially given, although it was noted when he went to surgery he was very tachycardic. His physical exam, he was awake, restless, and confused. He had tachypnea, and he had left lower quadrant tenderness with frank peritonitis. He was placed on IV fluids, given Zosyn, and transferred to the ICU. The family was counseled on the prognosis and his chances of recovery given his comorbidities and the state that he was in. They chose to proceed with surgery, so he was taken to surgery in an expeditious fashion. So I couldn't recover his initial CT scan before he came in to get his palliative stent, but this is an example of what an obstructive left-sided colon cancer looks like. So you can see it over here. Let's go over here. So I go back up and you can see it right here with a dilated cecum. So here's the placement of the stent in the GI lab. You can see the stent after it's deployed right here. And then this is the gastrograph and enema that was obtained. So you can see the contrast making its way to the stent. Here's the proximal portion up here. Distal. So as the contrast makes it to the stent, it's going out into the abdomen. So the operation that he received was an exploratory laparotomy with segmental resection of the descending colon, and he also got an end colostomy. Just the wrong slides. Oh, that's all right. Anyway, so the main points of the procedure were that he got a midline laparotomy. Gross stool was encountered immediately. The stool was suctioned away. The stent was visible initially. I mean, the stent was visible right off the bat. The bowel was stapled proximally and distally. The splenic, the descending colon and sigmoid colon were mobilized. An ostomy site was identified, and the ostomy and the bowel was pulled up into the ostomy. The midline was closed with zero PDS in a running fashion, and the ostomy was then matured, and he was taken to the ICU in guarded condition.
Did you resect the stent? I mean, was the stent left behind? I know you said.
I'm sorry. Yes, sir, it was.
That segment was resected.
Yes, sir.
Okay.
Proximally and distally
Okay.
to the
Gotcha.
perforated
Gotcha.
portion of bowel. So the pathology report showed colonic adenocarcinoma that was well to moderately differentiated. There was invasion through the submucosa and muscularis propria with extension into the visceral peritoneum. There was lymphovascular invasion. 3 of 5 nodes were positive, 11 tumor deposits, and there was the mismatched repair enzymes were intact. If you don't mind, I'm going to get out of this and get to the correct slides. This is an old presentation. Sorry. Okay. And so this is an example. I mean, this is the gross specimen, so you can see the stent perforating through the colon. So he did poor post-operatively. He was made comfort measures and eventually expired on April 29th, 2016. So this case is meant to illustrate the current evidence and guidelines that we have for colonic stenting. It's not this. So I'm going to tell you in broad terms what some of the indications are for colonic stenting. It's not intended to be an exhaustive presentation on colonic stents. It's going to focus mostly on left-sided obstructing colon cancer. And like I said, I'm going to try to present the most recent literature and the recommendations. So the first colonic stents were described as being used in 1990. Tajero and colleagues in 1994 described the use of stents as a bridge to surgery. So right now, for obstructing left-sided colon cancer, there's 3 main treatment options. So you can primarily resect the tumor and reanastomose. You can make a diverting ostomy, and you can put an endoscopic stent across the tumor. Currently, there's only really 3 sets of recommended guidelines. One was published in 2014 by the European Society of Gastrointestinal Endoscopy. The more recent ones were published by the World Journal of Emergency Surgery in 2017, which was published in 2018, and then the Eastern Association for the Surgery of Trauma published some guidelines back in 2016. And according to recent literature, the 90-day mortality of surgical intervention for a malignant colonic obstruction is 13.3% for patients having emergency surgery and 2% for elective surgery. So that information will come into play here in a little bit. So some of the current accepted indications for a colonic stent are temporary decompression in an acute malignant obstruction as a bridge to surgery, long-term decompression in an unresectable carcinoma, long-term decompression in benign colonic strictures because of fibrosis associated with surgery or radiotherapy, temporary colonic decompression in patients with diverticulitis to permit elective surgical resection, and then palliative treatment for the closure of fistulas. So there's only really one absolute contraindication, and that is clinical or radiographic evidence of acute perforation of the colon. And then some relative contraindications are the presence of a long segment of tumor, the lesions that are too proximal or too distal in the colon, and then lesions in tortuous portions of the colon. And so the last two are usually due to an increased technical difficulty and complications as far as poor outcomes with the latter two. And there's also no real good data out there on how long a segment of tumor should be that you can stent. So the current guidelines by the European Society of Gastrointestinal Endoscopy suggest that prophylactic colonic stent placement is not recommended. And that means that if you don't have clinical symptoms of obstruction, then you shouldn't place a stent just because you have a colon cancer. So they also say that bridge to elective surgery with the self-expandable metal stent is not recommended as the standard treatment in symptomatic left-sided colon obstruction. But they do say that if they have an obstructing left-sided colon cancer and they are poor and they have a high risk of postoperative mortality, meaning that they have an ASA class of greater than or equal to 3 or they're greater than 70 years old, it can be considered as an option. And they also say that it is the recommended preferred treatment in palliation, except when patients are being treated with anti-angiogenic drugs like bevacizumab. And so bevacizumab comes up time and time again in the literature as having an increase for perforation with colonic stents. So just briefly, bevacizumab is a monoclonal antibody directed against endothelial growth factor, and it results in reduced and delayed angiogenesis, and it's noted to increase the rate of GI perforation in multiple types of cancer. And just briefly, the ASA classes, so I just highlighted the greater than or equal to 3, so that basically means if, they have COPD, uncontrolled diabetes, they have had a cardiovascular event recently, then, they're increased risk for postoperative mortality. So then the World Society of Emergency Surgery published these guidelines they made these guidelines in 2017, and they published them in 2018. This paper was an exhaustive review of the literature and guidelines of all types of obstructing cancer, the preferred modes of imaging, what the consensus was on the most common symptoms that they could have. But with respect to obstructive colon cancer, they said that metal stents self-expandable metal stents should be preferred to colostomy for palliation, except when the patient is on anti-angiogenic agents like bevacizumab. They also said that as a bridge to surgery, that right now that self-expandable metal stent should not be the preferred mode of treatment. The literature that is out there is suboptimal, but for what we have, it does reduce colostomy rate, and the long-term outcomes appear comparable as well as the short-term outcomes. However, there's just not enough, they concluded that there just wasn't enough evidence out there to make a strong decision on that right now. They also say for obstructive right colon cancer, it's not recommended that you use a stent, but it is an option in high-risk patients and can be used in the palliative setting. So a little bit about why this is important. Colorectal cancer is the third most commonly diagnosed malignancy worldwide. Over 1.8 million new cases were diagnosed in 2018. It's the third most common cancer in men and second in women worldwide. It's the fourth leading cause of cancer death in the world, with almost 700,000 deaths in 2012. And according to Cancer.org, the U.S. is predicted to experience 51,000 deaths from colon cancer in 2019. And of note, large bowel obstruction represents almost 80% of the emergencies related to colorectal cancer, while the perforation accounts for the remaining 20%. The most common location is the sigmoid colon, with 75% of the tumors located distal to the splenic flexure. And perforation occurs at the tumor site in almost 70% of cases, and proximal in 30%. So this slide just kind of highlights some evidence that the location of obstructing malignancy is left-sided, and that in the literature published on this, on the stenting, they kind of suggest that makes these amenable to endoscopic intervention. And then one of the authors also demonstrated that the average malignant stricture length was 3 to 7 centimeters, and he was trying to imply that these were within a stentable range. However, there's really not any good evidence on what a stentable range is, although it's noted in a couple of papers that 4 centimeters of stenosis, once you get to that or a longer distance, the complication rate as far as not being able to deploy the stent and clinical failure do increase. And they also suggest that you deploy the stent 2 centimeters proximal and 2 centimeters, you have 2 centimeters proximal, 2 centimeters distal of the stent with respect to the tumor. So given this kind of conflicting evidence, we're still left with 2 main questions. Is there a worthwhile net benefit from endoluminal stenting for patients presenting with an obstructing colon cancer? And if a benefit exists, can you identify it in patients undergoing attempted curative treatment, palliative treatment, or both? So I'm just going to go over a couple of the key journal articles that I found. In the World Journal of Gastroenterology in 2016, they note that the decision of using a stent in patients with non-metastatic malignant bowel obstruction is one that is fraught with indecision due to the theoretical risk of perforation converting a once potentially curable disease to incurable. And so this is noted a lot. And in almost every single one of these papers and all these meta-analysis, they say that there's so much indecision and that it's just with the amount of literature we have out, or previously the amount of literature that we had out there, it was just no one could really come to any hard conclusions on what to do. And so they concluded in their paper in the management of physiologically poor patients with a complete bowel obstruction that metal stents are the preferred initial treatment of choice. In the fit patient, they say that surgery is preferred due to the physiological parameters and better outcomes and the potential for a one-stage resection. They also noted in their study that the cost of palliative stent was 50% less than surgical decompression, and that the expense of a bridge to surgery was reduced by 12% as compared to a two-stage procedure. So with regard to palliative stenting, this paper was published in 2018. It looked at mean survival, 30-day adverse events, mortality, length of hospital stay, stoma formation, the length of stay at the ICU, clinical success rate as judged by decompression within 48 hours, and technical success, meaning that the stent was able to be deployed across the stricture. So they found that the mortality, mean survival, and the length of ICU stay and early complications were similar for self-expandable metal stents and emergency surgery. Surgery was associated with a higher clinical success, but it also had a higher stoma rate of 84% versus 14.3%, and the self-expandable metal stents also corresponded to a shorter hospital stay and less permanent stoma. Some of the early stent complications, and these are highlighted in all of the papers as well, is that are perforation, migration of the stent, and reobstruction. And in this paper, they found that was 36.5%. Surgical complications were non-functioning ostomy, suture dehiscence, and volvulus, and they found that to be 24.1%. The average hospital day was about 17 days for a stent and about 35 days for emergency surgery. So they concluded that self-expandable metal stents may be an alternative for managing patients with unresectable obstructive colorectal cancer. Colon cancer. They said that it has the advantage of an early hospital discharge, and with respect to palliative patients, it says that they improves their quality of life and because they don't have to have an ostomy. So with respect to why perforation happens and in the self-expandable metal stents and the rate. This paper was published in 2014. It had 4,086 patients. So they found the perforation rate of colonic stenting to be 7.4%, and almost 70% of the perforations occur within the first week of stenting. They found that stent design, benign etiology, and bevacizumab were risk factors for perforation. Interprocedural stricture dilation and chemotherapy were not associated with increased risk of perforation, and that post-stent dilation was associated with an increased risk of perforation. And I just put this figure in here because the perforation rate with bevacizumab was double that with non-bevacizumab chemotherapy, and this was comparable to the perforation rates overall. This study was also, there's very few randomized controlled trials on this. So this study, including over 4,000 patients, still only had 5 randomized controlled trials included in it. And they also noted that their paper had a higher perforation rate with benign strictures they found that they did have a higher perforation with benign strictures versus other papers that said that there wasn't any difference in benign and malignant strictures because they included diverticular stricture in theirs, whereas other papers only included anastomotic strictures and Crohn's strictures. So these are a couple of examples of the stents available. There's a lot of different stents available, but these are just a couple examples. And then these are what we offer at Erlanger. So we offer the Evolution metal stent by Cook. It comes in one length, and it's 30 millimeters at the ends and 25 millimeters in the center, and it costs $2,082. It's also noted in the literature that it is the suggested diameter should be greater than or equal to 24 millimeters, because that has better outcomes and overall. We also offer the Wallflex uncovered metal stent by Boston Scientific. It comes in two lengths. It's 25 millimeters at the distal end and 30 millimeters at the proximal end, and it's a little bit more expensive at almost $3,000. So a couple more trials. So this was the CREST trial. It's the largest trial of endoluminal stenting for obstructing colorectal cancer. They aimed to determine if the endoluminal stenting for obstructing colon cancer reduced perioperative morbidity and reduced 30-day mortality. 246 patients, they found that the 30-day postoperative mortality was no different, the length of hospital stay was no different, and that stenting achieved relief of obstruction in 82% of patients. Stoma formation was much higher and was statistically significantly higher in the emergency surgery group. They found that there was no significant difference in quality of life, and that the 1-year mortality for potential curative patients did not differ between the treatment groups. So they concluded that in patients fit enough to undergo surgery, that a stent as a bridge to surgery reduced stoma formation without a detrimental effect on 1-year survival. And they found no difference between the postoperative mortality, length of ICU stay, length of hospital stay, critical care usage, and quality of life. The Eastern Association for the Surgery of Trauma put out a paper in 2016 because a lot of the trauma surgeons also do acute care surgery, and they wanted to create a guideline that could be used to help in the decision making for the care of patients with colonic obstructions, both benign and malignant, because again, the data out there, the synthesis of it has been poor, and the guidelines, there are few. So they looked at adult patients with colonic obstruction, and they wanted to know if they should undergo surgery or endoscopic stenting to decrease mortality, and if it would decrease emergency non-planned procedures. So they conditionally recommended endoscopic colonic stenting as the initial therapy for colonic obstruction. They found that it decreased mortality rates, and it also decreased the need for emergency non-planned procedures, which included reoperations. But it was a conditional recommendation because of the lack of evidence supporting benign colonic disease, so this is only applying to malignant colonic obstruction. And then finally, in 2018, this is one of the more recent kind of synthesis papers that I had seen. It was out of the MD Anderson University in Bangkok, Thailand, and Cleveland Medical Center. So they incorporated more clinical scenarios into their kind of recommendations, and they wanted to delineate the key factors considered when making an individual decision in order to determine the optimal treatment for the palliative and potentially curable settings. They found that based on the most recent literature, that patients with limited survival expectancy and they can halt or not undergo targeted angiogenesis, including bevacizumab, that endoscopic stent would be the preferred option. But diverting ostomy is preferred for obstructing rectal cancer. Because low-lying stent placements can cause pelvic pain, tenesmus, and incontinence. Ostomy is also preferred in patients who need to remain on anti-angiogenesis agents, given the delayed complication rates with stent use. And in the curative intent, they found that in a bridge to surgery that stenting was indicated, but it needs to be taken by a patient in case it's a patient and case dependent scenario. So what I concluded was that there's very few randomized controlled trials on the subject. The data is still controversial. We need more multi-center randomized controlled trials to evaluate the long-term outcomes of colonic stents and the individual risk factors for perforation, and we need updated guidelines to guide therapy. And then here's my works cited, but I didn't know if this would project well. I can get this to whoever wants it. I'm not going to go through it, but it was in that last paper that I showed you. They broke it down really well, I thought, and based it on the most current therapy. So that's kind of their algorithm.
Questions, comments? When we talk about using it as a bridge to surgery, I would assume that this allows you to tune somebody up with a cardiac situation, or maybe do a bowel prep. Is that the primary objective to the bridge approach?
Yes, sir. Just to kind of physiologically
are
optimize them. Yes, sir.
Are those the most common things you'd use it for? I don't know. Dan, you got the mic. Give one to Dr. Moore here.
So that was a really great review. In fact, there's just an article out in DCNR this last month that's looking at the same question. And I think this last one, even though you can't see this paper, I think this illustrates that this really is something that you individualize. I have a patient right now that we were able to put a stent in. He was obstructed. His albumin was low. He had a kind of edematous proximal colon, put a stent in. We were able to work him up and evaluate his liver lesion, which is isolated. And then I'll probably try to get Dowden to help me to do a single stage on this guy who otherwise had previously had poor nutrition. That's a good example. The one you gave, obviously it shows that there are complications. So I think you have to look at each individual person. Is it something that's easily stentable? What part of the colon is it at? What are your goals? And I personally like transverse loop colostomy as a temporizing measure on a thin patient. You can also, which you didn't have as a listing there, if they have like a mid-descending colon tumor, you can do an extended right colectomy with an anastomosis because the colon isn't real thickened and edematous. And that's the problem you get on primary resection, is oftentimes with an obstruction, it hasn't been something short-lived. Their albumin is low, their colon is edematous. It's not good for an anastomosis. You just end up with an ancolostomy, and there's a lot of morbidity in a takedown of an ancolostomy in some patients. So I think just to get an idea that you really have to individualize patients, it's a good tool to have in your toolbox. That's a nice talk, though.
Yeah, in this era of assembly line medicine, it won't work well here. You can't line up 3 or 4 of these to do in a day and expect it to all work out great. You got to be a thinking doctor and use judgment, and then have some good luck as well. Dr. Moore?
Well, I agree. It was a very good talk, and it's important that we be involved in this decision making because, as an anecdotal remark that Dr. Hunt got from one of the GI fellows was when he was asking about guidelines and when they do it, and the answer was,
he said, I don't know. He said, we usually just kind of do what you guys want us to.
So therefore,
do what now?
Do what you guys want us to.
Oh, okay.
So therefore, it's important for us to be the decision
They're a real
makers.
cerebral bunch.
And
GI fellows.
Well, we didn't want to go there, but there are some newer studies out with covered stents because you can cover stents, everywhere else in the body. So with benign disease, it's clear that you don't want to use a uncovered stent. They got covered removable stents now that are coming along. So I think stent technology is going to continue to progress. Clearly, it's not good in the rectum because of the pain, discomfort, migration, and but I think it's imperative that we all understand.
But just talking about benign, to me it would seem that there's a pretty substantial difference in what your long-term and even short-term goals are if you're talking about benign versus malignant disease, right?
We are, but,
and the papers seem to point that out for the most part.
Yeah.
There's that benign disease you still got to be thinking about. Let's do something definitive here, right?
Absolutely. Okay. It's not the answer for long-term benign disease, but then you do run into radiation strictures and things that. You know.
But the patient with malignancy, this may be actually their long-term. I mean, in this case.
Well, it has worked in. You know, we all have examples. One of our beloved teaching attendings here, he had severe liver disease and got a stent and worked every day after that and asked me every day when he was going to get his colon resection, which was never.
Yeah, right.
And he went ahead and passed away, you know, working every day until the last day before he died. So
yeah, right.
Working something.
Yeah, yeah, Bob.
I'm not an expert on this, but I will make two comments. One, I think the results of your stenting, as you have seen, are only as good as the proceduralist putting the stent in, and I think the experience of the person doing it has a lot to do with whether or not they're going to perforate them. I mean, unless the specimen was manipulated somehow to get that kind of perforation from a stent placement, that just looked like that one went really awry. I mean, that was horrible looking pathology specimen. I just don't know how you do that. But the thing that I noticed when we looked at this literature was that there was a higher long-term recurrence rate with stenting these lesions.
Okay.
And the stage 4 palliative that have failed that's where they use it.
Okay, all right, yeah. I didn't think it was exactly, it's not a frontline chemotherapeutic agent for colorectal cancer. Okay. All right, great presentations, both of you. Very well done. Thank you.